under Teams media today. She is the first clinical safety special interest group, and so I'm very pleased to welcome you all. So just to say who I am, I'm Sebastian Alexander. I'm one of the a founding fellow of the faculty, keen advocate of the faculty's work, and I also work for NHS Digital as strategic clinical lead for clinical safety with the clinical safety team, some of whom are on the call today. And I'm also a GP, a general practitioner, back in clinical practice at the moment and working in Cambridge. But very warm welcome. And I'm going to let each speaker introduce themselves when they come on very quickly. But I'd just like to say we've also got Joe Jubb and Jan, who are both working for the faculty and have kindly helped with pulling this presentation. And also I'd like to introduce my co-chair, really, who's there with Clive Tomset, who's clinical safety officer, and you may know his name, previous work roles in Cerner, but you may hear from him a bit later anyhow, so I'll let him introduce himself. So Clive's also been a great help in pulling this together as well. So a very warm welcome to you all. We are going to mute everybody automatically so we don't get any background noise, and we have got backup phone numbers, but hopefully this will work seamlessly, as we've all been using Teams a lot more in the last few weeks due to the COVID stuff going on. And so we're kind of getting used to the new platform. So we've got two sessions. First is 45 minutes long, apps and wearables, and the second is also 45 minutes long. So we're going to start really soon. We are aiming to finish at 2:30 on the dot because we have other meetings to go on to. I would like everybody to keep questions to the end if we could, and the questions will be via the chat line. And we hope that works satisfactorily. And I will coordinate the questions at the end of each session. So I think we'll make a slow start. Jan, did you just want to say anything?
No. Have you got any instructions?
Can I just highlight that the chat line isn't accessible to many of us? It says we have to give them permission.
Okay. Yes.
Okay. Well, can we work on that while we're going along? And we may have to resort to voice questions if necessary if we can't sort that. Thanks for that. We've used this before, but it did work last time, I think, from what we've been said. But we'll work on that anyhow. Good. Okay. So without further ado, I'd like to say welcome to you all. Thanks for joining. We've chosen two topical subjects, which we're all been intimately involved with in different ways. But the first is the assessment of apps and wearables. And I'd just like to introduce Wayne Shirt, who's our senior project manager on the team at NHS Digital, to give us a little bit of a background of himself, a bit of an introduction, and then go into the presentation. So I'm going to hand over to Wayne now. So Wayne, welcome, and we'll bring your slide deck up.
Thank you, Sebastian. So thank you all for attending, and thank you for giving me and Kryptowire, Mal and Chris the opportunity to do a presentation and a demo today. As Sebastian said, if you do have any questions, if you can, so to put them in chat. If not, raise an hand or speak, and we'll try and answer as we go along. Right, so I'll just wait for the screen coming up.
Can you see that?
Yes, right, yeah, my screen's just refreshed. So, as Sebastian said, my name's Wayne Sher. I'm a senior PM on the NHS Digital Apps and Wearables programme. I've been on the programme a month after it started back in 2017. And prior to that, I ran the assurance on GP SOC for 4 or 5 years. So I've got a background in suppliers, developers, providing clinical systems, software systems to healthcare industry, and working closely in an assurance capacity on GP SOC, fully understood the pain and the suffering, shall we say, that developers need to go through to to pass various bars and levels. So at one point I did have a dual role between the two, and then it was getting a little bit too much to continue as a dual role, so I moved across full-time onto the Apps and Wearables programme. So if you want to go on to the next slide, please, Joe. Just going to show you a quick output of the programme, which is the NHS Apps Library. It always surprises me how many people don't realise that we've got one. I know we don't do a lot of publicity, but it would be nice to do a little bit more. And just before COVID restrictions kicked in, we had put an updated comms plan together that we were going to get a lot more social media out there, so LinkedIn, tweets, etc., and just to get it out into the public domain. Next slide, please. All the links are on the presentation, by the way, to all the things I'm showing you. So this is just a flavour of some of the apps that we've currently got on there, on the library that have been assessed. It's by no means all of them, but it's just a selection, you know, to give you a flavour of what we've got. If you want to go next slide, please. So this is the vision or the programme brief that we were set up to deliver. And it all came on the back of a Secretary of State comment at Expo in 2016 that he wanted an apps library. The then Jeremy Hunt wanted an apps library, and it was stood up very, very quickly for February 17, but not as you see it is today. I mean, it's evolved completely from 2017 until now. So that's important. So it's enabling health and social care professionals, citizens and patients to access trusted digital tools and improve their outcomes. So the key part there is the trusted digital tools. So yes, it's an NHS apps library, but it's not just apps that are on there. I think if I remember rightly, we've got about 9 websites, a couple of text messaging systems, and we've only got one wearable at the moment, and we are looking to increase that. But we've been concentrating on the apps side of things for now. If you want to go on to the next slide, please. So we'd split, when we were given the brief, we split it into 4 what we call actors, or 4 users of the programme. So we've got commissioners, patients and citizens, healthcare professionals, and app vendors / developers, suppliers, etc. So to start with, we didn't want to go down the route of trying to build something that catered for all 4 to start with. So obviously the main part of this was for the public. So we concentrated on patients and citizens and app vendors, because we need the app vendors to give us the apps to assess for the patients. However, in January this year, again just before COVID sort of raised its head fully, we were asked by DH and NHSX to start to look at healthcare professionals and commissioners, and that's what we'd started to do. So you will see a small number of apps at the moment that are aimed at the NHS workforce. So we've got 2 at the moment. Pando, which is actually a COVID app, but it's a communications app that is healthcare professional facing, still accessible on the library, and you know there's nothing stopping a member of the public looking at it, but it has been commissioned by NHS England for the staff. And apologies, I can't remember the second one, but there are 2 at the moment on there. So if you want to go to the next slide, please. I always put this up because it's just a visualization of what people are searching for on the library. And obviously, I'm not sure if you've seen these before, these word graphics. The bigger the word and the brighter the colour is, the more that it's been searched for. So the top search words on the left are the words that people are actually typing into the search engine on the library. The one on the right is they're searching by categories. Now, this particular graphic I've put up here is from January. And if you take mental health as an entirety, so all the words that come under it and the category, we were averaging 1 search per minute, 24 hours a day, 7 days a week on the library for people wanting support and, you know, what services are out there, what apps are out there, websites, etc. And I run the report again yesterday, actually, just while COVID was on, and just for a meeting me and Sebastian was on with somebody else. That has now changed to 6 searches per minute on average for mental health issues and anxiety, etc. So 1 every 10 seconds. So it just sort of focuses people's mind, you know, that what services we can offer here, and hopefully try and divert some of the footfall away from primary and secondary care by giving people choice. You know, not everything can be managed by apps, obviously, and it should be seen as a complementary service, not a replacement of services. And that's one thing that we always get challenged on. I've stood up at Expo at a number of times now, and where journalists have ripped into us for, oh, typical government, you know, you're trying to get rid of services and, you know, swap them for IT. That's not the case. This is just a complementary to people who, and to patients and citizens who wish to use it. If they don't, they can still go down the normal route of, you know, GP consultation or, you know, managing their diabetes, for example, with face-to-face consultations. If you want to go on to the next slide, please. So the library is not just only the library. We do have, it's our central starting point for anybody. And as you can see on the blue arrow, we've got on the right hand side there how we assess the apps. And again, all these links are in the presentation at the end. And that takes you through the journey of what we do at each stage. So we're open and transparent about everything. And that's one of the key drivers that I insisted on when I came onto the programme. I had a nearly full-time role responding to FOIs, Freedom of Information requests, when I first started. And I said, look, you know, the more we can get out there into the public domain and be open and transparent and everybody can see, the easier my life would be, but also the more trusted that the process will be and more open to external scrutiny. And what we've done now, every single thing, apart from the responses to the questions, are now published. So we have the full question set published on our guidance pages. We have the acceptance criteria published on the pages. We have all supporting documentation. We have all links to external supporting documentation. So, for example, under clinical safety, we've got a link to the DCB 129 and 160 standards within NHS Digital. We've got the under data protection, we've got links to the ICO website that explains GDPR and takes the developers through it. We are looking to publish the actual results of the assessment online once we get COVID out of the way, and hopefully we get COVID out of the way, and then everything is out there in the public domain. We've also got on the same journey, just below the blue arrow, is the app provider journey of the healthcare professional. And again, if you're an app provider or a digital tool provider, you can click that and it'll take you through the various journeys, etc. So if you want to go on to the next slide, please. What we've done here is mapped out the journey from start to finish. So the DAC is the Digital Assessment Questionnaire, and that has been evolved since 2017. We normally do a new version once a quarter. I'll caveat that with an ish, depending on what's going on. We're now on version 2.3. We started on version 1, and that evolves with feedback from developers, feedback from assessors, feedback from subject matter experts such as Sebastian, who's chairing, and from people using the apps, etc. And we've evolved it over time. So the first part of the journey is what we call eligibility. And I was keen to get this up onto a website and to get this automated as soon as possible. At the last count, there was something like just under 500,000 apps worldwide that claim to have some healthcare relation in some way, shape or form. Now, you know, I'm not advocating that the majority are any good, but it's needle in a haystack. So we needed to get some criteria up into the public domain so developers knew what apps we were looking for at the time and what we would accept. Now, the eligibility criteria when we first went live was linked into what was then the 5-year forward view. It's now evolved into the long-term plan. So we've been a little bit more relaxed on the eligibility. So the developer would click on the link on the website that I've just shown you on the library that says I'm an app provider. It would then take them to the eligibility questionnaire and they answer the various questions. if they are successful in answering those questions, and they are questions like, what does the app do? What category does it fall into? Is it complementary to a service? And a couple of other legalish type questions on there, which are, does your app contain any NHS branding? Because that's quite key. We get quite a lot of developers who use branding and shouldn't be using it. So we wanted to sort of stop the ones who are a little bit less scrupulous, shall we say. So once they've gone through eligibility, they get an automated email back to say that they've passed with login details to the DAP, which is the Digital Assessment Portal. And that is where we manage everything. And what we want to do is keep all the information in one place. So regardless of what the developer is, what the subject matter expert is, or what the assessor are, they're all logging into the DAP to do something. So they register their product and their organisation, and it's one organisation to many products. So we're allowing the bigger developing organisations such as Roche Pharmaceutical, who have a number of apps, or even Public Health England, to only register once but have multiple apps. They then have the evidence of outcomes. When we first started, obviously we want apps on there and tools that deliver a benefit to the public or to healthcare professionals, and it's important that they can demonstrate that. And that could be case studies, that could be randomised controlled drug trials, etc., commissioning feedback. There's various aspects of the evidence that we require for them to be successful in that section. We then move on to clinical safety, and clinical safety is completely aligned with DCB 0129, if applicable to the app, because I mean obviously some apps don't have any clinical benefit, they are more sort of well-being or digital tools, etc. We've then got data protection, which is obviously aligned to GDPR. Now, data protection can vary from 4 questions up to about 200 questions, depending on what the app does and what the developer does. Are they a data processor? Are they a data controller, a data manufacturer? But what we do at every single section, we, for want of a better word, spoon feed the developer through each section, and every question has question logic in it. So if you answered yes to one question, you would see a different question next to if you answered no. And that way we're able to tailor every single journey that a developer makes to make it unique and as pain-free as possible. So we're only asking them what we need to ask them. We then move on to security, which we use Kryptowire, which Mal will come on to in a moment once I finish this particular slide. But the basics again on security are that the developer asked a number of questions. Oh, sorry, did somebody want to ask a question? Or? Oh, sorry, I just got some feedback. I didn't know somebody was speaking. So we asked the developer a number of questions, as we do with all sections, and then we pass it into the Kryptowire system. Usability and accessibility are obviously key. There are various questions that a developer must answer and must demonstrate their compliance with. Interoperability is only applicable if they are claiming interoperability or there is a need. So if they are connecting to one of the national systems, i.e. IM1, GPSOC, EPS, etc., then they must supply relevant information and evidence that they are interoperable. And then technical stability. What we don't want to do is get an app out there that is going to fall over when great numbers of people start to use it. One of the upsides of getting an app on the library is it gets a lot of publicity and it gets a lot of use. The last thing we want to do is put an app out there that falls over when more than 15, 20 people start downloading it, etc. So we need to make sure it's stable. So once we've gone through all those particular sections, hopefully they are published onto the library, the NHS Apps Library. What we've done with the library, it is just one output of the DAP process, and it's fed by an API from the DAP process that publishes it onto the library. We were again before COVID looking at using that same API to open it up to the likes of the primary care providers, so EMIS, TPP, etc., for them if GPs wished to prescribe apps or to at least recommend, they could use the API to to bring up, say, diabetes or smoking cessation, and it would list the apps in that particular category that had passed the DAP process. And also, we're in conversations with Crown Commercial Services to get some of these apps onto what's called the G Cloud framework for government and local government to be able to procure these apps. So a benefit of going through the DAP process is not just getting on the library, it's opening the door to getting you possibly commissioned as a developer by either other healthcare providers or local authorities for sort of social care, etc. Next slide, please. I think, is that Mal? Oh, great. Oh, sorry. Yep. So this is just the route in a little bit more detail, where we've got various people and various organisations and groups coming into the digital assessment portal. So obviously we've got the developers, we've got the commissioners that we're starting to look at and to engage with now, where another output from, another consumer of the API would be a commissioning portal. And unfortunately for me, we'd just done a prototype at the beginning of February, which we were getting fantastic feedback from for a commissioner portal, and then COVID came along and we had to pause that. So that's something I'm wanting to pick up pretty soon after, and that's for CCGs and probably anybody on this call really who wants to commission an app or find out what we've already got in progress, rather than having to repeat procurement exercise, time and time again. If there's something like 270 CCGs in England, and if they all want to procure the same app, at the moment we're all doing the same IG, but all or very similar IG, very similar clinical safety review, etc. Why, when we've done the majority, there will always need to be a local procurement from a commercial point of view, but the majority of everything else should have been taken care of by what we've done at a national level. So reducing the burden on the front line again. If you want to, next slide, I think it brings a little more up on the, yep. So a major part of the DAP is the continual assessment. So once an app has gone through and it's been published, part of what the Kryptowire system does, and apologies Mal and Chris, I don't want to steal your thunder, but it does a continuous monitoring of Apple and Google stores to let the team know, my team know, if the app has changed. So no longer can a developer shall we say, sneak into the App Store a new version that's not been assessed. We know instantly that they have done so. Part of a license agreement that a developer signs with us is that they should be telling us before they make any changes, and we can then plan to do a re-review of the certain sections. I mean, for example, they may only be changing, say, a colour screen or a spelling mistake. That's fine. But if they're adding new functionality in there, then we need to assess that new functionality for in relevant areas. It could be a new clinical diagnostic tool. It could be something from a security point of view. So it's not necessarily a full DAP end-to-end re-review. It could just be certain areas within the DAP. And then, as I said earlier, the API there is consumed by various parts of the program at the moment. Next slide, please. So this is just giving you a quick snapshot where we are today. So we've got a 15% referral rate. So for the non-techies out there, that means that for every app, every visitor that visits the NHS Apps Library, at the moment, 15% of them, or 3,000 a week, then go on to download the app from either Apple or Google. At the moment, we've got 91 apps. When it says in production, it actually means published on the library. I've got another 2 in the queue that have been sent today, so that'll be up to 93 this afternoon. Important one, nobody gets through first time. So nobody fails the DAP, but you're either in progress or you pass. And to give you an example, back in sort of middle of 2018, we had a tri-party from Oxford Uni, King's College London, and I think it was Roche Pharmaceutical, had built an app and they submitted their application. We had a few email exchanges because they were getting quite, shall we say, uppity, insisting that they should be rushed through because, they are world leading and, there's nothing wrong. And unfortunately for those guys, they didn't pass a single section first time. So we gave them feedback and gave them opportunities where they needed to refine their product, and it took them about 4 months to go back and refine what they'd done. And a lot of it was obviously around GDPR and usability. From a clinical point of view, if I remember rightly, it was very good, but they'd not taken into account other aspects of app development and usability, etc. The 232% increase visit to the apps library is not including the COVID figures. I looked at it again, as I said earlier, earlier this week, and the last figure was something like 4,500% increase since COVID kicked in. So obviously more people at home, more people are looking for digital solutions that enable them not to have to go out, into the wide world, etc. And we've got 355 apps currently in the pipeline that are being processed. Some have only just started and some are very close to being finished, and the rest are in between. Next slide, please. Mal, I think it's over to you from Kryptowire. I don't know if you need to unmute him, Joe, or Sebastian, and mute me.
Yeah, thanks very much. Thanks, Wayne. That's really helpful.
Yeah.
We're going to unmute Mal just to come in on this point. So Mal, thank you very much.
Hello, can you hear me? Hello?
Yeah, I can hear you.
Right, thank you. Hi, my name is Malcolm John. I'm a strategy advisor with Kryptowire, and I basically represent Kryptowire in the UK. Thanks very much, Wayne, for that run through. We're just going to discuss the security and sort of data protection elements at the moment, because that's where Kryptowire is being used. And I thought I'd start by just putting up a clause from the National Institute of Standards and Technology. It's a US publication. It basically says what's happening is in line with good practice, and the NCSC in the UK refer out to the NIST anyway. A key element of the apps library, as you can see, it's growing, and there's an awful lot of those 500,000 health apps out there that aren't particularly good. But in other words, it's scale. And how do you secure that at scale? If you had to look at security and privacy and doing manual testing for it, it's just impractical in this scenario. So there's a need to standardize, automate, and then validate these submissions. So next slide, please. So this is where Kryptowire comes in. We've basically delivered a leading cloud-based automated mobile application security testing solution, and we automatically test the security and privacy of mobile apps to stringent standards. So the NIST and there's the NIAP standard, which is basically what the NSA used. Obviously, that's too much for most people, but we also do OWASP and others below it. And looking at that, we were jump-started in 2011 from DARPA, DHS, and NIST. I know not everybody's familiar with DARPA. That's the Defence Advanced Research Projects Agency. Essentially, it's where loads of cool stuff comes out, and they've got, from a UK perspective, they've got a heck of a lot more money than us to spend on research. So, and we've got a very good prestige customer base. And one of the main things is that we've got actionable results in less than 2 hours. So next slide, please. So just a quick view of the portal and how it's worked. Obviously, there's the clinical assessment where we get to in the process here. You've got the DAC submission and the app itself. And Chris will go through this in a demonstration very soon. But essentially, the app's uploaded. The NHS analyst uploads the app onto the portal. Kryptowire does its stuff, and in less than 2 hours comes back with a very detailed reports about the security and privacy of those apps. The analyst reviews those results, and then he can actually say, yeah, that sounds fine, or no, we need to have a discussion with the developer to try and improve in these areas and stuff. One key point is, though, that if there's an app on an apps library, so the NHS apps library, it will be assumed to be endorsed and fit for purpose. And so one of the things Kryptowire is doing is we're basically on an independent view, which is standard based on the security and privacy of those DAC submissions. So next slide, please, Joe. So just before I hand over to Chris, I just wanted to point one main thing out here. Because of the apps library, because of the apps library and what it's doing is it's basically reliant on thousands of different developers doing their job well. Well, you can be a creative developer or even a good clinician who's develop a good clinical app, but it's not necessarily, and certainly at the moment, not every creative developer is a secure developer, shall we say. So there's a number of things that we need to look out for when we're doing this. So I'll park that there for now and hand over to Chris. I think, Joe, you need to stop recording and stop sharing so that Chris can share.
Yeah, that's right. I've just stopped recording and